Hello, I'm Susan Wray, Editor-in-Chief of Physiological Reports, and it's my pleasure today to speak with Matt Muller of Penn State about a paper that we've just accepted in Physiological Reports. The paper is entitled Effect of Adrenergic Agonists on Coronary Blood Flow, a Laboratory Study in Healthy Volunteers. Matt, could I just ask you to introduce your team of authors and viewers?
I'd be happy to do that. Again, my name is Matthew Muller. I'm an assistant professor at Penn State Heart and Vascular Institute in Hershey, Pennsylvania. That's part of Penn State College of Medicine. And you'll see throughout this study, we really do basic and translational science, but we're doing it within the context of a clinical infrastructure that a level 1 hospital provides. The first author of this paper, Alvaro, is a third-year medical student, and we had some imaging specialists, cardiologists, internal medicine specialists, and another medical student, as well as a collaborator from Penn State University in University Park. So our team is pretty diverse, and we have a lot of different approaches that we use to try to understand how coronary blood flow is regulated.
Thank you very much, Dr. Muller. Yes, I was struck by the diversity of your team, and I guess this is partly due to the fact that what you're trying to do is work with humans and use non-invasive technology. So could you just briefly explain some of the challenges that this sort of work brings with it?
Sure. I consider myself a human physiologist, and in particular, our lab studies how the sympathetic nervous system controls blood pressure and blood flow in humans. So we really are halfway between animal physiology that you might see in dogs or pigs or rodents and clinical care, the clinical care that you see in the intensive care unit or in the operating room, trying to understand how blood pressure and blood flow are acutely regulated. So to do these type of studies properly, you really need to be in a hospital with physicians physically present in the room when the infusions are going, because there's a high degree of risk. If things go wrong, these agonists can be catastrophic. So we have to do things very carefully, and there's a lot of regulations. The IRB process itself is quite lengthy. And when I was thinking back at this IRB protocol I wrote, it actually got rejected twice by our institutional review board because they just found it to be too crazy. They didn't like the fact that we were doing these agonist infusions in healthy people. And I said, well, we don't know exactly how these drugs work. We know in general how heart rate and blood pressure are changed if you give these medications in the intensive care unit, but we really don't know at all how coronary blood flow is affected. And that's important because coronary flow is the main way that the heart muscle receives oxygen. So the challenges include the IRB process itself is lengthy. The recruitment is challenging because not everybody wants to volunteer for a study where their heart rate's going to be racing for 32 minutes. And we had to do a lot of screening tests in order to safely enroll people in the study. So exercise stress testing and DEXA scans to measure lean body mass and blood markers. And the time needed for the subjects to participate is quite long. It's 4 to 5 hours each of these studies. And the scheduling is challenging. We need to make sure that our cardiologist and our hospitalist are both available. So it gets to be very challenging to schedule. But in the end, we have a really great team of people. As I mentioned, physicians, nurses, imaging specialists, medical students. And so we also have the Clinical and Translational Science Institute at Penn State, which provides some infrastructure to do these studies. So we had a high degree of control, and this is the perfect type of study for a junior faculty member like me to be involved in.
Yes, I mean, I'm even more impressed now. Now I realise just all that, how much time it takes, and as you say, the intensity of the team. So could you then, again, just set the scene? I think painted very nicely for us, the overall picture, but what were the specific objectives of this study, Matt?
All right. I've had a long interest in coronary blood flow regulation ever since I came to Penn State Heart and Vascular Institute. And the overall lab really cares about the sympathetic nervous system and how the body regulates blood pressure and blood flow during exercise. But we really don't know how the adrenergic receptors in the heart, in the coronary blood vessels, are stimulated. And so we wanted to do some studies in healthy volunteers to figure this process out. So we really had to blaze some new trails with the agonist infusions. And so we used isoproterenol, which is a non-selective beta agonist. We used terbutaline, which is a beta-2 selective adrenergic agonist. We used phenylephrine, which is an alpha-1 agonist. And we also used epinephrine, which is more of a endogenous, physiologically relevant, but it has mixed alpha and beta effects. And we infused these in healthy humans and measured coronary blood flow velocity with Doppler echocardiography. So this is a measure of the blood flow velocity moving through the left anterior descending coronary artery. This is the main artery that feeds the left ventricle of the heart. So we had to blaze a lot of new trails with the agonist infusions because these dosages are not used clinically, and we wanted to have a lot of experimental control. So we infused the drugs based on fat-free mass or lean body mass because that correlates best with blood volume. We really were trying to advance a lot of prior studies that have been done in dogs and in pigs, and also in patients undergoing cardiac catheterization. Feel that a lot of those cardiac catheterization studies had limitations because those patients are going to get a lot of sedatives and opioids in the cath lab. They also have a high degree of atherosclerotic risk. And many of those studies did not account for heart rate and blood pressure because we know that coronary blood flow is very tightly regulated by cardiac metabolism. We feel that's a really important thing to do. So in the end, that's what we did. We developed a non-invasive protocol, imaging protocol, and we gave intravenous drugs and quantified as many physiological parameters as we could.
Excellent. And did you also, am I remembering correctly, you also involved a degree of exercise in one of your protocols? Is that correct, Matt?
That's correct. We did use isometric hand grip exercise, which is a laboratory intervention that raises heart rate and blood pressure. It raises sympathetic nerve activity. Because when heart rate and blood pressure increase, cardiac metabolism increases, the feedback process that results is a net increase in coronary blood flow velocity. The thing is that people that have higher heart rate responses might have a higher degree of vasodilation in their coronary arteries because their cardiac metabolism is high, but they also might have higher coronary blood flow because catecholamines are stimulating the beta-2 microvascular receptors. So there's a lot of things we're trying to figure out why coronary blood flow goes up. So we did include an exercise component in addition to all of the adrenergic infusions.
Thank you very much. Matt, what would you describe as the key findings from this research?
The key findings, first of all, is that these infusions are safe and feasible to do in human subjects. I think that was a new trail that we blazed with the IRB. They made us report after the first 5 subjects the safety profile of these drugs. So moving forward, that very much helps us in the lab. But the big physiological findings are that coronary vasodilation occurs during isometric hand grip exercise, during isoproterenol infusion, during terbutaline, and during epinephrine. Now, phenylephrine, the alpha-1 agonist phenylephrine, causes a rise in blood pressure, but because of the reflex bradycardia that is observed, the change in rate pressure product, which is our index of cardiac metabolism, actually did not change. So with phenylephrine, we still need to do some more work.
Right. So that brings us on very nicely to what direction, what are the next or the most imminent experiments you're going to be doing?
The next studies we're going to do are to look at these differences between men and women and between older and younger subjects, and then also to investigate this process in patients with disease. The original intention of this IRB protocol I wrote was to look at group differences and look at how therapies such as exercise training or dietary interventions could improve coronary hyperemia or coronary vasodilation during physiological stress. We think that's an important prognostic indicator of overall cardiovascular health. That was the original intention, but in this study, we really needed to lay the groundwork and establish that everything was safe and that we could measure these things in the lab. So moving forward, we have a lot of momentum, and the patients are now willing to participate and come back for more visits. I think our nurses and our physicians are comfortable with the infusions, and technically we can make the measurement. So that's the next step, is to look at age and sex differences in these responses.
Matt, thank you very much for that. We wish you very well with your studies and await the outcomes of those with interest. And as you know, Physiological Reports is an open access journal, so I hope we help you spread the message about your studies. Thank you again, Dr. Muller, and your team.
Thanks for having me.